This is going to be topic 41, shock disorders of central circulation.
You will understand how hypertension places a patient at significant risk for myocardial infarction and heart failure, stroke, and renal failure. The recognition that most EMS calls results from a patient's inability to take medications regularly or from poorly controlled hypertension. The field treatment is often directed at the results of the hypertension, not at reducing the pressure. Chief concern. Hypertension, there are three classes. They have lasting effects on the body. The patient may have hypertension for several years before becoming symptomatic or hypertension is discovered. In general, blood pressure does not need to be lowered acutely in the pre-hospital or emergency department environments. Elevated blood pressures. Hypertensive emergency. Severe hypertension that results in acute impairment of an organ system. There's also acute hypertension episode. Patient presents with stage 2 hypertension, but not signs or symptoms of end organ damage. And we're going to look at the stages here in just a second. Hypertensive urgency, acute hypertensive episode without evidence of end organ damage, even though the patient has risk factors to develop acute end organ damage. Hypertensive encephalopathy, abrupt increase in the patient's blood pressure can cause a lack of blood flow through these narrowed cerebral blood vessels, increase damage to those vessels, and cause cerebral edema. Manifestations itself as altered mental status, seizures, or visual disturbances, and this would be from the hypertension. So essentially, on a very big scale in the brain, from the increased hypertension, we get a shift in fluid. That shift in fluid in the tissues then causes the brain tissue itself to inflame and swell. All right, so this is table 25.1, the Joint National Committee classification of hypertension. Pre-hypertension would be a systolic blood pressure 120 to 130 millimeters of mercury, or diastolic blood pressure of 80 to 89 millimeters of mercury. Stage 1 hypertension, systolic blood pressure 140 to 159, and then a diastolic blood pressure 90 to 99. Stage 2 hypertension, systolic blood pressure 160, or a diastolic blood pressure greater than 100. This is figure 25.1, the effects of hypertension on the body, and there are several of them. The brain, cerebral perfusion pressure, or CPP, it's dependent on the mean arterial pressure. If the MAP increases, as it does with hypertension, the cerebral perfusion pressure also increases as well. So this is what can give us encephalopathies in the brain. Heart, systemic hypertension increases pressure the left ventricle needs to overcome to maintain the body flow of the body. So essentially, the hypertension itself becomes more than the ejection fraction on the heart. Brain. The kidneys. Decrease the diameter of the blood vessels within the kidneys limits the blood flow to the kidneys and impairs the kidneys' filtering function. And that brings about a whole lot more problems. It's kind of like a domino effect. Peripheral blood vessels. Damage includes development of aortic aneurysms or peripheral vascular disease or peripheral nerve damage, and even erectile dysfunction can occur. So these are complications of hypertension. Cardiopulmonary manifestations are chest pain under pressure. They can have a myocardial infarction because of poor perfusion to the coronary arteries. A sudden increase in hypertension is greater than the heart's ability to overcome the patient's afterload, and the heart begins to fail is why. Renal manifestations, generalized itching and altered mental status caused by the loss of kidneys' filtering ability and the buildup of nitrogen in the blood. That's why they're itching. We can also get some pregnancy complications from this, like pregnancy-induced hypertension, preeclampsia, and eclampsia, and they typically occur during the late part of the second trimester or third trimester. History. Situations vary. We should gather information and determine if hypertensive episode is producing end organ damage. Ask directed questions. Neurological. Whenever we're looking at it, does the patient have headaches, double vision, vision loss, numbness, and weakness? On the cardiovascular side, cardiac-related symptoms, chest pain, pressure, EKG changes. Renal, generalized itching, skin color changes from the keratin, decreased in urination from low GFR, glomerular filtration rate, because of the high hypertension and the constricting of the vessels there. They don't see as much blood, so therefore they don't make as much urine. And then confusion. Pregnancy, possibility of a recent delivery. This can be even after they've delivered, postpartum, that they can have pregnancy-induced hypertension and or eclampsia or preeclampsia. History of disorders, hypertension, diabetes, cardiovascular disease, renal insufficiency or failure, known thoracic abdominal aneurysm or an abdominal aneurysm, prior embolic or hemorrhagic stroke should also be considered. Any of those disorders should come up as a red flag, so to speak. On examination, primary assessment considerations, correct immediately any kind of life-threatening conditions in the ABCs. Airway assessment is essential. Determine if it's something simple like blood glucose, so use your altered mental status approach here on this. Physical exam considerations, neurological side, any kind of problems with the brains or neurological function, things like AVPU, LAPS, or Cincinnati profile on them. Cranial nerve assessment would be awesome as well. Cardiovascular, auscultate the heart for murmurs and the lungs for rales. If we continuously beat up the valves in the heart from back pressure, they can regurgitate a bit, so we may find a murmur on these patients. Signs of aortic aneurysm, palpate their abdomen for the presence of any kind of pulsating masses. Renal side, examine their skin for color, check for uremic frost. That would be a key indicator of decreasing kidney function, and evidence of scratching, and that would be from the nitrogenous waste still left in the tissues. On assessment, acute neurological process symptoms, headache, vision loss, considerations on this, long-standing history of any kind of hypertension. So if they got a history about it, if it looks like a duck, walks like a duck, and talks like a duck, good chance it might be a duck. Risk for chronic end organ damage, and then if they get into over the 220 range, or they look like they're going into end organ failure, consider it a hypertensive emergency. Treatment, controversial on the treatment on these patients. Asymptomatic patients with elevated blood pressure, we don't really treat them in the pre-hospital setting. Primary assessment considerations, we should always protect the airway and provide ventilatory support. Signs of heart failure, if we're having actual congested heart failure, and this would be peripheral edema, associated jugular venous distension, and now it's causing rales. They're extremely hypertensive. Nitrate treatment would probably be the best thing to do in CPAP to provide alveolar recruitment. Hypertensive urgencies, elevated blood pressure and risk factors for end organ damage, and we don't really have an acute treatment for that in the pre-hospital setting. Watch them, get them to an appropriate facility. They're going to monitor their blood pressure for a while, treat primary medication conditions if appropriate, and offer transport to the emergency department is pretty much what we do for the hypertensive urgencies. On evaluation during transport, monitor and reassess their blood pressure, their mental status, their airway, ventilations are being provided. Intubated patients, be sure and have them on waveform capnography, and their vital signs very frequently, and watch for trending. Disposition, closest emergency department for patients requiring any type of airway management or ventilatory support. In the case of hypertensive emergencies, also closest emergency department. If they think they're going to provide end organ damage or they're going to blow a vessel somewhere, they'll generally start initiating treatment on the hypertension itself. If the hypertension is caused from a stroke or a neurological concern, cerebral perfusion pressure equals the mean arterial pressure, or the pressure that might be inside of their head, minus the mean arterial pressure. So if you rob them of the blood pressure may be what is perfusing their brain. Specialty facility transport if they have a STEMI event or if they have signs of stroke. In conclusion, common conditions that is insidious in onset as hypertension. Many complications of hypertension are preventable. Most develop because patients do not suspect they have a problem with their blood pressure. Many patients access the emergency medical system when either their blood pressure is elevated or when they develop symptoms. Blood pressure control is a long-term goal. In the vast majority of patients, aggressive reduction in the patient's blood pressure in the ambulance and in the emergency department has a potential to do more harm than good.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, Smith Arts Samaritan EMS OK.com or 405-492-8243. Thank you.